we're going to kick it off and start our first session. So I'll pass it along to Anna, who is the moderator.
Thanks, Delane. Hi, everyone. My name is Anna Sampson, and I'm excited to be moderating today's first session where we'll get to hear from Rob Bottas and Alex Haggard on the politics of expressing pain. So a little bit about me is that I live with chronic pain in the form of ankylosing spondylitis and inflammatory arthritis and fibromyalgia and a few mental illnesses, all of which began in early adolescence for me. This led me to become a disability rights advocate and get involved in research as a patient partner to bring the patient perspective to research. So before I introduce the session and the speakers, I'm going to go over some general housekeeping, and I'll probably repeat some of what you've already heard, so bear with me. If you are in a crisis during the conference and need information about where to seek help, that is available in the exhibit area in Feed Loop. That's towards the left of the menu bar. And just a reminder that closed captions and simultaneous French audio translation are available. To access these, please follow the Zoom link posted in the session description on Feed Loop, and you can find that by scrolling down on the session page. And finally, please send any questions you have for our speakers through the Feed Loop chat on the right for this session or through the Q&A function in Zoom. Now that we've covered the basics, let's get into today's session on the politics of expressing pain. It's my pleasure to introduce Rob Bottas and Alex Haggard, who will be discussing how what we know about pain affects the experience of pain. So I'll start with you, Rob. Rob Bottas is the author and editor of 14 books, most recently Knowing Pain, A History of Sensation, Emotion, and Experience. He has also published dozens of academic articles, book chapters, and has written popular essays for Eon Magazine, History Today, and Psychology Today. Currently, he is a senior research fellow at the Academy of Finland Center of Excellence in the History of Experiences, Tampere University, Finland, and a fellow of the Royal Historical Society. Next, we have Alex Haggard. So Alex Haggard is a design researcher and patient advocate. Their work bridges critical disability theory, sociology of medicine, and user experience research with the goal of improving health and community care experiences for disabled people, and particularly for people whose disabilities tend to be invisibilized by society. Their work is informed by their own lived experience of chronic pain, neurodivergence, and mental health difficulties. Currently, they co-chair the Chronic Pain Network's Knowledge Mobilization and Implementation Science Committee and work as an equity and accessibility consultant in the digital health field. So now that we've introduced our speakers, I'm going to tell you a little bit about the session. So today, Rob and Alex will be talking about how pain is expressed, discussing how it is learned, practiced, and performed, and how the power dynamics at play when expressing pain. This conversation about the history of pain, ranging from ancient times to the present, will explore the shifting politics of expression and the meaning-making processes that produce painful experiences, taking seriously the relationship between physical and bodily pain and social and emotional suffering. Now I'll hand it over to Rob and Alex to introduce themselves and get things started.
Thanks very much, Anna. Thanks for the introduction. I just wanted to say, in addition, by way of introduction, that it's good evening from me rather than good morning, because I'm 10 hours ahead in Finland, where it's dark and snowing. But my home and my heart is in Montreal, so it's lovely to be in Canada right now, even if it's only virtually. And I would say as well that while I have been working on pain, the history of pain and in pain studies for about 20 years. I think I've been working in pain for about 30. So this part of, at least part of what I do is inflected through my own experience and trying to put that into a certain place and a certain narrative. So, hello.
Similarly, yeah, I'll add the context that, yeah, obviously I live with chronic pain. I began experiencing chronic pain, first that I remember, at least when around age 4, and I didn't receive a diagnosis until I was 30. So that is very much what motivates my interest in advocating for and studying what I call invisibilized illness, which is illness that the clinic, that the medical clinical system constructs as invisible. So things where it can't identify a specific cause for what's happening, and therefore tends to treat it as, as psychological, as made up, or as non-existent, and really trying to examine how that construction came to be and why it happens. And I think something that's really interesting with these invisible or invisibilized illnesses is the way that they've sort of been separated out from the history of disability rights, which have often focused on particular sorts of disability that are pathologized by the clinic in a specific way. So that when medicine tells you that there's something wrong with your body and or mind, whereas my experience has very much been years and years of being told that there was nothing at all wrong with me, and that I was either imagining it or, seeking attention or what have you. And for me, I think when we talk about making meaning, I think there's a fairly crucial difference in that experience. I think a lot of the material consequences that come out of it are similar in terms of, people with disabilities of all kinds and living in poverty, not being able to access the supports that they need. But they're like within yourself, there's a really significant element, I think, to being denied your material reality. And I think that's something that really interests me about your work, Rob, is this attempt to unpack the meaning or many meanings throughout history of pain. And I think also the way that studies of pain have often focused on acute pain, whereas I think you delve quite a bit more into pain in all its complexities, including chronic pain.
Yeah. I mean, everything you say kind of, to me, it rings really true over a very, very, very long time. And I was motivated in part by what I felt was an overwhelming kind of cry of anguish from the archive, which has never actually been validated as what it was. And we have, I think, professionally across the disciplines, nurtured a tendency to take people as speaking metaphorically, which is, I hear what you're saying, and now I'm going to translate it into what I think it means. There hasn't been much will, especially in the historical profession, to take people at their word. And when you do take people at their word, it creates a new set of problems, which is like, well, how do I actually understand or begin to understand these testimonies, essentially, whether they're spoken or embodied in some other way that has left a trace? And for me, the real challenge is, how do I understand what people mean when they say that they're in pain, in their own terms, and that in the context in which they lived, and in the context in which they had to try to maneuver and make whatever kind of claim they needed to make. And it's a very difficult process because it involves rebuilding worlds to try to understand, to try to resist that temptation to ventriloquize them, to translate, to say what they must have really meant, and instead try to understand, no, what do they actually mean? So in a way, I've been looking for that invisibilizing process over a couple of thousand years, and looking for the kind of tactics and the practices and the skills that people use to try to get themselves heard. And in my to give a kind of summary conclusion to all of that effort, I think that my main observation is that to be heard has been historically and remains an enormous privilege. To be heard means that you know what to say or how to practice your pain in a way that will be validated. And that's whether it's by a medical authority or say a religious authority or a magical authority, depending on where you are and when you are. So I'm really motivated by this. There's a line in the latest official definition of pain about the ultimate test of whether a person is in pain is if they say they are. And my view, based on all of these records, is that it's still very difficult to say that you're in pain and have it heard, right? So you're still missing so much by making pain an article of privilege.
I love that you mentioned that, because my experience has very much been that I have lost the ability to know when I'm in pain, even like going even beyond being able to communicate or express being in pain. But over years of, and especially sort of starting in fairly early childhood and over years of being told by, people who should know that I was not actually in pain, or that whatever I was experiencing was normal, like I learned to tune it out to a very significant extent. And to the extent that a couple of years ago, I sustained a mild break of my wrist, and I was using a wheelchair at the time, and I was wheeling around for a week, and I did not realize that my wrist was broken. I thought, oh, it's a little sore, but like that, it's very difficult for me to be able to actually recognize my pain as pain, and therefore also to perform it accurately, sort of when I get to the point where I do seek help for it. It was also similarly sort of around my mid-20s when I was finally diagnosed with a sleep disorder, because as much as sleep disorders are also heavily stigmatized by the clinic, it is at least sort of harder to ignore when someone is falling asleep, fully falling asleep spontaneously. They'll still construct it as, a lifestyle and behavioral issue, but at least, you can pretty easily see when someone is falling asleep. But as that was happening, I was sort of dealing with a lot of other symptoms and trying to seek answers for what was going on there and whether that might be underlying the sleep disorder. Turns out it was. And I remember someone suggested to me that I might have Ehlers-Danlos syndrome, which is a connective tissue disorder, causes hypermobility of the joints, as well as a whole slew of other things in other tissues and systems. And I said, no, that's not possible because I don't have chronic pain. And then at a certain point, like a couple months later, I was sitting on the sofa watching a movie over Skype at the time with my friend, and I was shifting around, and all of a sudden it sort of hit me. I was like, it's probably not normal to not be able to sit still for more than 10 minutes without needing to move because it hurts. And from then on, I started noticing more and more and realizing, oh yeah, none of this is actually normal. And recognizing that I was in fact in quite a lot of chronic pain. But even so, it is still very difficult. I find, like, when you sort of go in for an issue and they ask you how much pain you're in, like rating on a scale from 1 to 10 is, I don't know, like for me, a 3, I'll say I'm a 3, and then I'll receive a medication that helps with some of my pain, and I realize, oh, that was not a 3 that I was in before. So yeah, and I also really, really like what you said about the cry from the archives, because I think that for me, when I sort of do my research, which I do not have nearly enough time for, but as sort of a non-affiliated researcher, I don't have access to as many of the resources. So I sort of tend to rely on secondary sources, history of medicine texts. And it's striking to me how much of what we do know or think we know about the history of medicine and of illness is very much defined by not even sort of ill people with privilege, but by, figures of authority, by doctors, and the way you sort of have to read between the lines to find hints of that pain and of that invisibilized illness. I think that's so interesting.
Yeah, there's tons of great themes in everything you said that I would love to explore. We definitely will run out of time. What you said about breaking your wrist and not really knowing and not being able to really tell how much pain you're in or how to rate it. I mean, this is at the heart of what I wanted to say with this book about the relationship between what you know and what experience is like. Because to some extent, how your experience in chronic pain is like, and this is, I'm not speaking to you directly as but a person, a generic person, experience is absolutely pegged to a kind of watered down, usually, understanding of a formalized pain knowledge. And somebody has to give you that script. Someone has to tell you the terms of what pain is and how it feels. And your experience of your own pain is, if you like, a continued experiment of testing how you feel against how X authority says you're supposed to feel. And if you're super lucky, how you feel will fit exactly into the categorizations that have been made for you in a given time or place. But of course, most of the time, there's a degree of misfit. And that experience of misfit also does something to your experience of your pain. It adds a frustration quality. It adds a different kind of suffering because it's an inability to sort of land the expressive punch, if you like, with the right person. But also it's teaching you a kind of denial, right? And you see this again and again in so many different contexts that people learn to underrate their pain, right? Because they have been somehow denied that their own expressions didn't fit the pattern that was cut and made for them. And specifically, your mention of the pain scale, I think that it's a really convenient logic to have a pain scale, to make it metric. 1 to 10, where are you? And I always thought in the abstract, compared to what, how are you supposed to know? Because between no pain at all and worst pain you can imagine, and to me anyway, dividing those other segments up is a very difficult process. And yet the answer you give will then set a ball rolling in a certain way, at a certain speed, in a certain direction, which is your treatment or how seriously you are taken. And there isn't an easy way to hack this system either, because you can't go straight to 10 because then you've got nowhere to go, right? And it involves the kind of patient memory as well, like what did I say last time, and so on. So to me, this whole thing about there being a script, it's not like a written down script. No one gives it to you. No one tells you. In fact, medical authorities throughout history would be in a position to deny that it exists. And yet you need to know it, and you need to be able to read it well. And if you can, maybe you can do better in terms of the treatment you get. And if you can't, then you're out of the way. And I think that it's not just that when we think about the history of pain being written by pain authorities, I think that goes hand in hand with the fact that the very concept of pain has been written by authorities. So everything that you say in a clinical encounter, and probably will be quite different to what you would say to a friend or a family member or someone you know personally. But like what you say in a clinical encounter, that language, for it to work, is not your language. It's been pre-supplied, it's been pre-formed, it's been pre-categorized by medical authorities. Not the one sitting in front of you, but somewhere out there, it's been supplied. And one of the things I was trying to do in this book was to actually do some of that archaeology, if you like. Well, where does this language come from? Who supplies it? When did it emerge? Where does it come from? And in almost every instance, it's not even remotely interacting with or interfacing with people who might have actually been able to tell them.
I remember when we were planning this session, you talked a little bit about the McGill pain questionnaire, and I'd love for you to talk a little bit more about that, because it's sort of, it's treated as it's treated as something that works really well. I would say it's probably closest to the best that we have within the clinical system, but yeah, I really appreciated you discussing sort of the flaws with how it was constructed and how it's been adopted.
Yeah. Well, I mean, I feel very, in a way, quite close to the McGill pain questionnaire in certain ways, because when I'm not here in Finland, my second intellectual home is at McGill, and I've spoken to the pain center staff there in the pain rounds about the McGill pain questionnaire, and of course, for those people, it's a tool. It's what they use unthinkingly every day, and I wanted to kind of just show them its origins and maybe its flaws and maybe its politics and some of the problematic things about using it. So I mean, it is used as like the gold standard still, I think, for people to express their chronic pain, in particular, in supposedly a subjective way, using affective terms as well as sensory terms, and as well as indicating parts of the body. So it seems to be covering all the bases. And within each category on the McGill pain questionnaire, there's lots of options for your pain to fit into. And I just asked, well, where do all these categories come from? Who set the limits for what pain can be like and how it can be described? Because a lot of these words are quite figurative. For example, burning pain. You don't have to be on fire to have burning pain. It is a metaphorical term, and yet it's a standard term. And it turns out that there wasn't really any patient consultation at all in the making of the McGill pain questionnaire. Basically, couple of guys sat down with some medical dictionaries and came up with a list based on their experience of dealing with people in the clinic, what the sort of the overall delimitation of pain experience was. It was then tested on a very small subset of patients from a white working class neighborhood in Montreal. Very small. And almost without revision, it was sort of launched into the world. And because there was nothing else, it became very quickly, everybody wants it. And since then, it's been translated into dozens of languages on the assumption that the categories that Ron Malzak especially came up with for the pain questionnaire were not only very close to what a patient might say, sort of off the cuff, but also universal. So then people in different parts of the world started to translate the McGill pain questionnaire, and they ran into all kinds of problems because they looked at it and they said, oh, well, you can't have shooting pain in Italian, and all different parts of the pain questionnaire didn't work in different countries. In some places, like in some countries in the Middle East, for example, Kuwait, they decided that this really didn't work for chronic pain at all. It only works for acute pain. And again, decisions based upon people, as it were, in the establishment deciding what will and will not work, and what kind of patient it could work for. Like, oh, well, it won't work because you have to be educated to understand this, right? The politics of the McGill-Payne questionnaire slowly come to the surface through the problems people had in translating it. And yet still, almost everywhere, it's considered like one of the go-to things, especially for chronic pain. So when you're given that and asked to fill it out and essentially express your pain, you have to understand that you are being asked to express your pain in someone else's language, and a language that was set down middle part of the 20th century, based upon medical experience with a relatively small number of people. And that's bound, it's going to help people, but it's also bound to miss people out, and it's bound to miss some people's pain.
I think there's something so interesting too about this idea of metaphorical or figurative language with pain, because in my experience, sort of in community with people in chronic pain, there is a lot of, I would say, less metaphorical and more analogous use of pain. And to what extent that's influenced by this idea already that we have, that the terms that are available to us are and need to be sort of figurative. But it's also interesting to me because in my own personal use of, I guess, analogous language, when I sort of pick apart the analogies, they're often actually not, they're not really metaphors at all. They're actually very literal sort of transpositions of what's happening. So when I have a subluxated or dislocated joint, the actual feeling of the joint itself, not sort of the muscle pain around it or anything, I often describe as feeling like I have a pebble stuck in my shoe, except it's in between my bones. And when you think about the actual mechanism of what's going on, that is very much sort of you have bone grinding up against bone and against tendon, which is very much sort of what you would like. There's something in the spot that it shouldn't be, which is very much sort of the sensation of the pebble in the shoe. And so I sort of, I wonder if there were sort of like, deeper listening, much more of a qualitative approach to the figurative language that patients do use. We actually might be able to unpack a lot more about the mechanisms of what they're describing and the relationships to what we know about types of pain, rather than sort of trying to fit it into this pre-existing framework. And I think like many things, it points to a much greater need for sort of qualitative research skills training within diagnostic work, because ultimately diagnostic work is, or at least should be, very much a qualitative research process.
Yeah, I think so. I mean, it comes back to that notion I mentioned before about taking people at their word or literally. And, I think that, pain studies is a very multidisciplinary environment. Like, there's hardly any discipline that it misses out, but they don't necessarily talk to one another too well across the disciplines. And my feeling is sort of taking a broad look at medical education and the history of medical education and the amount of time within a medical degree that you spend talking about pain. It's incredibly small still in most med schools. So then you're asking people who maybe have a kind of rudimentary mechanical notion of pain or pain function, and a really rudimentary social understanding of how pain works in terms of how it feels, what it means, how experience is made. You're asking those people to be the front line in diagnosing and offering therapeutic choices. And it seems to me that it would be much better if at that point the multidisciplinarity of pain studies was better represented. Which isn't to say that like someone like me would feel particularly confident or qualified. But somewhere along the line, I think someone like me and people like me should be in the curriculum, so that at the point of diagnosis, there isn't such a kind of narrow view of what pain is. And I mean, historically, I see exactly the same thing. I mean, if you go back past the 20th century, then most of the cases of pain that I was dealing with were in a religious context. And I think that it's a really useful thought exercise to look at a source of someone, say, in the 18th century or whenever, medieval times, talking about their pain in religious terms and feeling so far from what they're saying I don't understand what this person is talking about. What will it take for me to begin to understand what this expression means? And it strikes me that that kind of humility before a person giving testimony would be a useful skill to have in the clinic now.
There's also a sort of going back to what you said about the privilege of knowing and expressing you're in pain. I mean, something I would very much like to see is a greater role for patients within their own diagnosis, sort of like actually greater power to be like, this is what's happening to me, and to direct themselves to the care that they need. But then sort of as you mentioned, even knowing what you're experiencing is often a factor of privilege and is so much defined by these sort of systems of power that tell us, you know, what things are valid things to feel and what those mean. Like that presents a huge barrier to actually, like, it's not a straightforward thing to afford patients more agency, more power within that system.
No, it's not a straightforward thing. I'm hugely motivated about this, and I think that primarily what is needed is a toolbox. So when I was writing this book, but other things I've written as well, you know, historians in general, they're uncomfortable in the present. I'm uncomfortable kind of projecting myself in the now or to the future. But what I can do, and what lots of other people can do, is provide, if you like, a very open book about our methods of understanding what it is that people are saying, and our methods of understanding the political dynamics of a clinical encounter, right? So that's a huge thing in the history of medicine, but most historians of medicine don't talk to the general public, let alone a targeted group of people who have lived experience of pain and want to better sort of vouch for themselves in the medical arena. They talk to other experts. So there's a real problem with how we communicate what we do. And my aim is, if I can show you how this works, if I can show you that the question, how do you feel, or rate your pain today, if I can show you that these are political questions and not neutral questions, if I can show you how to interrogate that politics and empower yourself by so doing, then, I mean, I'm not then determining what happens, but I think I can give people tools to better navigate their way through whatever system it is they're in. And I can't do that by myself, of course, but if people in pain studies address a different type of audience, I think there is a lot of potential. Of course, that remains completely nebulous and vague, but I feel like we're starting from, well, the ground floor, really. There is an endless amount of improvement that could be made when it comes to the way that, especially chronic pain, which is very distinctly late modern problem, can be experienced in a better way and dealt with in a better way.
I think it's interesting too, sort of to compare, you know, the difficulty of sort of shifting these systems with the ease with which something like the Miggles-Paine questionnaire gets taken up. And I'm wondering if you can sort of speak to that at all, the why, sort of the difference, I guess the dynamics of why it is so sort of seemingly easy for these things to be taken up when they come from within the system versus sort of trying to influence it as what's perceived as an outsider, at least.
Yeah, well, I would compare it to an historian trying to get himself heard by the medical establishment. The very first thing, the very first barrier is, what's your authority to speak? Like, where's, you know, compared to my expertise, what is yours? And I think that that power that comes from expertise, education, that it inheres in institutions, it inheres in funding, it inheres in a kind of pharmaceutical logic also, very much. It's really difficult to get over those barriers. So I find it difficult as a kind of, you know, part of the scholarly elite, but it's a different thing for me to talk to historians than to go and try and talk to doctors. So if you're, you know, a person getting on with their life, and you know, you want to make yourself heard, like you have an idea, how on earth do you float that? So I talk a little bit at the end of the book about the way that there's been a real presence and a growing presence of community groups and collectivities. Community is really the wrong word, because these people they exist together only in an online environment on single issue things, whether it's fibromyalgia or endometriosis or whatever it is. There's a group for it, and I think that they do actually do something. The problem is that often the dynamic I see is that they set themselves up oppositionally to medical authority, and in setting themselves up oppositionally, they risk, at the least, not getting the people they need most to listen. If you can be shut down because, you know, I don't want to hear that, then you lose, right? So I saw this recently. I'm working with a team here in Finland, and it seems that there are have an anthropologist colleague who's working on pediatric chronic pain, and there are parent advocacy groups trying to make a difference. They are very much alive to lived experience questions and politics, but they have set themselves up against the pain clinics, to the point that the pain clinics now don't even want to call pediatric chronic pain, because it seems to signal a green light to the activists who are trying to change the way that therapy works. Seems nothing productive comes out of this. I mean, you see the political dimension all too clearly, but somehow you have to build bridges, even if it's unpalatable, instead of burning them. And I am not saying that it's easy. It's not. And I can guarantee, I promise, that in the history of pain, most people, most of the time, have failed. But it has to be worth the effort.
I think it's so difficult, because honestly, my inclination is not to make peace with clinicians, because I think, like, there's also a dimension of trauma, right? So many people have experienced so much awfulness that it's trying to build bridges with a system that has hurt you so much is so difficult. And at the same time, I think a thing that I've come to recognize over the past several years of being involved in sort of advocacy work within the design field is that being overtly adversarial only works if you have a certain amount of power already. And when you are coming in with very little power, often sort of it does not get you what you need. And so I've started to think of this in terms of like, we actually, not even necessarily, but sort of compromising, but we need a way to make enough peace to be able to go in and subvert, I think, to shift the systems as we need to. But in order to be able to make those shifts, you need to get in. And I think that's a little bit different than sort of the, the stereotype of working within the system. It's not about sort of necessarily even making incremental changes, but it's about getting in and getting enough of a relationship of influence and power within that system to be able to then and finding the strategic ways to present the shifts that need to happen as well. Because I think in a lot of cases, there are so many inefficiencies in the way that we diagnose and treat pain. And as much as I hate to appeal to sort of an economic argument, there would be economic benefits to doing a better job of diagnosing and treating pain. And I think sort of, being able to get in and frame it that way is sort of a necessary strategy. And also, I think there's something interesting to what you mentioned about the way that chronic illness, chronic pain groups tend to be single issue and specifically single diagnosis. And I think that is I think that's something that we're starting to make progress on in, with something like this, a chronic pain conference more generally. But that is, I think, where it's sort of that distinction between the history of disability rights and the history of invisibilized illness becomes really important, because as you see, there's been this sort of coalescence of a lot of other forms of disability, but invisibilized illness specifically has sort of always been left outside of that. And I think, it's often framed as a resistance of people with invisibilized illness to identifying as disability. But I think one of the reasons I try to do the research that I do is to explore the ways that actually people with invisibilized illness have been systematically shut out of disability rights activism and sort of accessibility activism as well. And I think that's an important piece of the puzzle.
Yeah, agreed. I could speak to that, but I think we're butting up against Q&A.
That was such a great discussion. I know you guys probably want to talk even more, but we have a couple questions coming in. So a question we've got from Samantha Kelly is that a big frustration of theirs has been the pain scale, particularly recently while filling out disability forms. When they don't know what to choose, their physician often says, just pick one, I need to put something. And they've recently started refusing to answer. What are your thoughts on that? And is there a better way to answer this impossible question?
No, there isn't. I totally sympathize with you in that situation. Unfortunately, if you are in a situation where the pain scale is presented to you and it's for whatever needs to happen next, this thing is given as compulsory, then you are in this political situation in which you have no power. And within the confines of that situation, or any argument about the bogusness of this way of measuring you in some kind of taking something subjective and turning it into something objective, you can point it out till you're blue in the face, and it's not going to make any difference. And that's why I was saying before, like, being asked to rate your pain, it comes with also remembering what you said last time, maybe leaving yourself room for more painful days, working out what is the ideal fabulation of my current feeling that will get me where I need to go. Like, if it's a 7, can I be 8 next time? Do I have to look a certain way? How do I address the fact that, like, yesterday it was definitely a 9, now it's a 6, but I want to convince the person in front of me that the 9 yesterday was important. So is it 9 now? What about the guilt that comes with putting this 9 now, right? It's endless quagmire. I think that the answer is to try to tackle these problems outside of the immediacy of that situation. And that's for people to be extremely active in demanding better ways of having their pain assessed in the first place. That is, I don't want to circle an emoji. I don't want to give you a number out of 10, right? And until there's a kind of critical mass of really patient-led and ally-led activism to change the way that happens, then I'm afraid we're stuck with it. And in that moment, all I can do is say, go with your gut, because yeah, probably putting nothing is that's a good way of registering your scorn, but it may not also lead to the best outcome for you in the end. I suppose there isn't a spinal tap option of just say it goes up to 11, man. Like,
I'm laughing because I've literally gone through this in the past week, because I get sort of regular injections for migraine, and yes, there's a form every week, and they've recently increased it to 2 forms, which is interesting. The form that you fill out on the day of asks you about your pain over the past week, and then they've now, with the appointment confirmation, started sending a virtual form which asks you about your pain in the last 24 hours. And as I was trying to fill it out last week, I was trying to sort of strategize. I was like, I'm having actually a pretty good day. I'm going to wait a couple days until I have a worse day. I mean, I could have just, like, I know what my worst pain is usually. I could have just, estimated, but that is the autistic tendency in me to be extremely literal. Anyway, yeah, it is a very relatable struggle. And I will also say, like, my strategic answer, which is very similar to Rob's, is also different than my emotional answer, which is that I have done very much the same thing as you. And I think it very much depends on context too. Like, I have been in situations where it was pretty clear to me that the clinical interaction was not going to get me where I needed to go. Like that the physician was not sort of believing me, was not really interested in supporting me, in which case I do tend to be more combative, I would say, because I figure at that point it's a lost cause. I may as well use this as an opportunity to hopefully do some education, hopefully that, once the discomfort of the moment is past, they will maybe sit with it and do better in future. But at the same time, like with something like disability forms, where it's something that it's very much something that you need and you don't have a lot of other options, I would say, yes, it's something where, as much as it rankles, you need to be strategic about, you need to think about, like, what is the outcome that I need to get from, really, in either situation, it's what is the outcome that I need to get from this, and then sort of proceed accordingly. And I would also say too, like, yes, if you have the capacity, whatever capacity you have, to get involved with advocacy, with activism, with patient partnership, that is the way to make change. And also, I will say, like, for me, that has turned a lot of trauma and a lot of emotional and literal physical pain into something, speaking of the meaning of pain, it has turned it into something more positive for me. It allows me to make a more positive meaning of it by, using my experiences to hopefully shift things for other people in the future.
Thank you. Elizabeth was asking if there is a standardized scale that explains the levels, like, for these forms specifically.
No, there isn't. This is one of the key parts about pain experience that I think it would be counterintuitive to most people, which is that there is no predictable or a universal relationship between a kind of sensory damage, or even an emotional event, and how painful it is. So and even on the same person on 2 different days could have the same thing happen to them and have 2 different kinds of pain experiences. So there's a long history of people trying to come up with objective ways of measuring pain and standardizing. Okay, a 4 means X. You know, a 4 means X in terms of skin sensitivity or blood pressure, or whatever kind of functional phenomenon you want to put on the number 4, but it doesn't work. It's never worked. And every time someone tries to make it objective, it fails.
There's one, and I can't remember the name of it, but it tries to sort of provide an explanation of what each of the levels is. But what's always striking to me is I think it's 1 or 2 is sort of rated as a bee sting. And the thing that I always think is, but what if you're allergic to bee stings? And I had that play out in a clinical setting a couple of weeks ago. I had an intake with rheumatology because I've been having some new sort of seemingly inflammatory joint pain. And I was trying to explain, again, sort of using analogical language. I said, it feels like when I get a mosquito bite, but happening inside my joints. And then I realized I need to explain, I get what's called Skeeter syndrome. I get essentially an allergic reaction to mosquitoes. So when I say mosquito bite, it means something different than what the average person's mosquito bite probably is. But sort of from a practical perspective, I would say, and like, this is not perfect too, because again, it depends on the extent to which you've learned to dissociate from your pain. But, you know, the effect to which, the extent to which it's affecting your sort of day-to-day functioning is sort of what I go with when I'm asked to rate my pain. That's sort of the only way I've been able to find that works. And then I usually bump it up 1 to 2, because I also know that I've gotten very good at dissociating from pain. So I can function pretty well in quite a lot of pain. So I always just bump it up a couple, because yeah.
Thank you so much. I think we're at time for our Q&A, but any questions that were left unanswered the discussion will be continued in the feed loop chat. So no worries about that. Your questions will be answered. Thank you so much, Rob and Alex.
Thank you so much for having us.
Wow, what a wonderful conversation. I really appreciated that. I hope everyone learned as much as I did.